So it's just preparing to live stream. So it'll be done
Okay.
in like 5 seconds. Okay, and we are live. Hi everyone, hi web shadowers. Thank you all for attending this session today. Today we have the pleasure of hosting Dr. Shah, who will be teaching us about rheumatology. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end of this session. With that being said, Dr. Shah, you can get started whenever you're ready.
Thank you, Sophia, for that kind introduction. Hello, everyone. Hello, web shadowers. Thank you so much for having me today. I'm honored to be talking to all of you in a beautiful virtual way, talking a little bit about rheumatology, what the field is about, me personally a little bit, and then we'll review a few cases to just discuss a few examples of rheumatic conditions, patients that have rheumatic diseases, and of course, we will leave time at the end to answer any questions that you might have as well. So again, my name is Dr. Bhakti Shah, and I am a rheumatologist that practices in the New York region. I actually grew up in New York. This is just a little bit about me and my background. I did my undergraduate in New Jersey Institute of Technology. I did a major in biology with a minor in business. People will always ask, what is the best major to pursue when you are in your undergrad years? And honestly, I chose biology just because I have such a love for science and that's where my interests lay. But you can do a major in anything that fits you best. In medical school, I had colleagues that majored in finance. I had friends that majored in English literature. As long as you are able to finish your prerequisites for medical school, which includes a few biology classes, maybe some organic chemistry, a few math classes, you can really major in anything that suits you best. I chose to minor in business just for a little bit of a different perspective on medicine. In your future, in your careers, you will see that business is an important part of medicine too. And I wanted to gain a little bit of an understanding of that aspect of medicine as well. So I chose to minor in business. I did medical school in New York also, State University of New York in Brooklyn at Downstate Med School, where I spent 4 years. Then I went on to do internal medicine residency in Northwell Health in Long Island, and I stayed there for my fellowship as well. And I currently am practicing in a private practice in New York. So the journey in medicine is definitely long, but overall very, very worth it. These are how many years I personally had spent getting my education. So I did 3 years of undergrad, 4 years of medical school, 3 years of internal medicine residency, and then 2 years of rheumatology fellowship. And that is a total of 12 years of higher education after high school. So, I was fortunate enough in high school to have the ability to take a lot of college classes ahead of time. So when I was a senior, I did a lot of AP classes, and I also did some college classes at my local college as well. So I was able to gather a lot of college credits even prior to my freshman year of high school. I entered college with about 31 college credits, which really helped in shortening my years of undergrad. I had spent my summers also doing a couple summer classes, and I also did a lot of research during that time as well, which was able to help me get into med school. And I know that right now, most of you are either in undergrad or you may even be in medical school. So I want to be able to answer any questions that you have regarding extracurricular activities or research or what to do to try to amp up your application for medical school. So please ask your questions and I will try to answer them along the way as well, because this is a very critical part of getting into medical school and then succeeding in your future career as well. So I did internal medicine residency after medical school. You usually decide around your 3rd year of med school what exactly you want to be doing for your future. I knew pretty early on that I wanted to do internal medicine. I was one of those kids growing up in elementary school that always knew that I wanted to be a doctor. So it kind of really helped me narrow my career options, because that is really what I had always had a passion for. So I went right into internal medicine. Now, internal medicine is a very broad field. You can have you can practice as a general internist, which is usually your primary care doctor that you see, Or you can do a subspecialty, which is a further specialty training in internal medicine. So you'll hear of many fields: cardiology, gastroenterology, endocrinology, rheumatology, infectious disease, nephrology. These are all subspecialties of internal medicine. And you don't have to know from day one what exactly you want to specialize in. I always want to emphasize to keep, to keep our options open. Do not have tunnel vision. Do not be too geared onto one specific career path very early on. I didn't know I wanted to do rheumatology until my first year of residency. I was interested in immunology and the pathophysiology of the immune system. About my first or second year of medical school is when I started to get intrigued by it. But even when I was in med school, I still really loved gastroenterology. I had my thoughts on rheumatology, nephrology. But really, after I did an elective during my residency in rheumatology, that is when I really said, I think this is the career path for me. But keep your options open, keep a broad mind, try to get as much out of your rotations in medical school as possible. When you are an undergrad, broaden your horizon, take a variety of different classes. Medicine is not just science and math. There is a lot more that's involved too. So use your time now to really learn as much as you can about various different fields and try to gain some insight onto the details of each field and try to see what fits your personality and what you are looking for. There are a few questions. I'm going to try to get to them. Did I go from undergrad straight to med school? I did, yes. So as I said, I knew very early on that medicine is what I wanted to do, which is why I tried to shorten my undergrad years. Do I regret that? Would I go back and change that? No, I wouldn't. But I often have wondered what it would have been like to spend one additional year in undergrad. Would I have traveled? Should I have taken some extra classes? Should I have learned a new language? I don't know. But looking back, I don't regret it. It really helped me kind of move through at a quicker pace. And because of that, I was able to finish medical school at 25. And I was able to finish all my training by 30, which seems late, but a majority of doctors end up really starting their career in their mid-30s. You get your first job when you're about 30 to 33 on average. Like I said, long journey, but very, very worth it. And when did I realize that I wanted to go to medical school? So again, very early on. I was probably in elementary school when I said I wanted to be a doctor. And then starting in high school, when I was able to, I spent my summers volunteering at the hospital. I actually volunteered at Baxter Brothers Hospital in Poughkeepsie. I'm from there. So I spent every summer, 9th grade, 10th grade, 11th grade, volunteering there as a patient care advocate, not doing anything major, just helping patients, giving them their newspapers, talking to the nurses. I volunteered a little bit in terms of, on the cancer ward. I would walk around with an ice cream cart, just very little things at that time. And then I also would shadow one of our local doctors in their office at the summers as well. Learned a little bit about how to take vital signs and how to get an interview, how to do a patient interview. So I spent my summers in high school doing that because I, again, knew very, very early on that I wanted to pursue medicine. So even my whole journey that I laid out for my undergrad was geared towards a career in the medical field. So the classes that I took, the major that I pursued, the minor that I pursued was all based around that. Do you recommend graduating early from undergrad if you can? So that, again, I just touched on that a little bit. It's a very personal choice. It's very, very personal. There is beauty in getting a full undergrad experience. You can make your lifelong relationships with your friends. You can learn a new skill, hone in on new talent, maybe have the ability to travel. Maybe you can even study abroad. I mean, in the COVID era, I know that there's a lot of limitations on all of this, but if the option is available to you, and if you want to have a full 4-year experience or even longer, go for it. If you want to accelerate your path, medicine is what you want to do. And if you have the ability to shorten your path, that is also something you can do. There are combined BSMD programs, 7-year programs, 8-year programs with certain medical schools. There are several in the New York region, and I know there are many scattered across the country too. It is a personal choice. You only go through this once, so whatever speaks to you, please follow your heart on that. And do the clubs that you're in the clubs that you were in, did they relate to medicine or science? Some of them, but not all of them. In college and in medical school, I was really big on student government. In college, I was part of what we called our student senate, and I partook in these weekly meetings. It was basically student government. I was part of the South Asian Student Association in my undergrad. I did a lot of volunteer work. I was an EMT in my undergrad years. So you can do a lot as long as you're involved in some sort of extracurricular activity that speaks to you, that you can discuss at interviews, participate in something that is of interest to you. Of course, science-related fields would be great. I know in a lot of undergrads, there are, pre-med associations. Join those just for networking and learning a little bit more about whether a career in medicine is right for you. But it is important to be involved in extracurricular activities. And along with that, research is very important. You don't have to, participate in groundbreaking clinical research, but majority of colleges are associated with some type of hospital or some type of medical facility where you can participate in some type of research. In my undergrad years, I spent a summer doing research in neuroscience. I mean, I didn't pursue a career in neuroscience, but I did research in that type of field. I spent 3 to 4 months working with a neuroscientist doing research, looking at, the effects of progesterone on learning and memory. I didn't pursue a career in neurology, but that medical background gave me insight on how much I still love medicine, and also was a great talking point for applications. You don't have to publish major research, but if you participate in something that you can really talk about, you are able to conduct an experiment of your own, working alongside a scientist, it will not just benefit you in terms of realizing that medicine and science is something that you love, but it will also in the future give you something to really discuss at your interviews moving forward. This is a great question. What would you say are the defining characteristics medical schools are looking for in a potential student in terms of personality and social skills? So that is the purpose of the interview. The best doctors are not just people that are smart. It are the doctors that are the most empathetic, the most passionate, the most kind, the most friendly, the ones that can have a great bedside manner. Those make the best doctors. I know people that had perfect GPA, 44 on their MCAT, and still didn't get into medical school because they just didn't have the personality for it. Med schools, there's not just one box of characteristics that med schools are really looking for, but as long as you're able to just be kind and friendly and compassionate, I think those are really important traits of a doctor. And I think that, your merit is always going to speak for itself. But like I said, being smart is not what's going to make you successful only as a doctor. Just being a general good person, being compassionate, empathetic, sympathetic, and dedicated. Medical schools want to see students that are dedicated. And that is why also your extracurricular activities and what you're doing outside of school is really important, because you can display dedication. If you are part of a volunteer organization in your community, if you are the captain of a dance team, if you are, the president of your student government, these are not things that are medical related, but it shows dedication and it shows leadership, and it can really tell more of who you are as a person, more than just a GPA can. So, there's not one checklist that med schools are using. I wish there was, so that it'd be easy for everyone, but there is no checklist. Of course, academics are important. They want to see what is your GPA score, what is your MCAT score. They want to see, did you do research, extracurriculars? But the purpose of the interview is to see what kind of person are you? Will you make a good doctor in the future? Are you going to be available for your patients? Will you be able to comfort them in times of their most vulnerable periods? That's what medical schools want to see. How did you balance your personal life with your medical journey? Well, when you are a student in medical school, education is really going to be a priority. So I was in med school from the age of 21 to 25. So those are considered prime years. I had friends that were traveling and they were already working and they would have their weekends off. And oftentimes they sat there and wondered, well, Why can't I have my weekends off? Why am I studying on the weekends? Why can I not have a paycheck? Why am I not working? Why am I still in school? Why am I still a student? Those thoughts, of course, crossed my mind. But when you are in school, when you are pursuing your training, you have to keep in mind what the long-term goal is here. It is hard. It's hard. You're going to be making sacrifices during residency and fellowship. Oftentimes you're working 60 to 80 hours a week. You're working weekends, you're working nights. It's hard during those times. You will miss things. You will miss family events. You will miss dinners with your friends. You'll miss weddings, baby showers. You won't be able to travel as much, but it is all okay because it's all so worth it in the end. And take my word for it. I finished all of my training about a year and a half ago. Right now, I'm working 40 hours a week. I have weekends off. I'm not working nights. Life is balanced. I have a great predictable schedule. I chose a career in rheumatology because of that balance that I can predict. I'm not rushed into the hospital at 2 a.m. I'm not going to be called in on my weekends off. The journey is long and it's hard, and I'm not going to tell you that it's easy, but I promise you it will be worth it. You will find balance. Even when you are in medical school and residency, and even in undergrad, when you're spending your weekends studying for your MCAT, just keep in mind what all of this work is for. It is so that you can become a doctor. It is so that you can impact thousands of lives, save thousands of lives. And at the end of the day, you will have everything and more. After I finished my training, I traveled, of course, pre-COVID. I traveled, I saw beautiful places, and I reminded myself of what I was so worried about before. I was so worried I couldn't do any of those things, but I have been able to do everything now. I was able to date. I got married during my residency, married my college sweetheart, which of course helped because I had already known him for so long. But, we were able to do all of that, even despite being in medical training. You can find the time to do things for yourself and others, but do not compare yourself to people that are not in medicine, because it will put you down if you're stuck in a phase where you're comparing to all your friends that are working and have paychecks and are traveling and are free on the weekends. It will bog you down. So do not think of that. Do not compare yourself to those that are not in the field. Just focus on the goal at hand and then think about what the long-term goal is. And I promise you will get through it. And do you work with any PAs? Did you consider anything other than medical school? Right now, in my practice, I work in a very large multi-specialty practice. So there are nurse practitioners and physician assistants that are part of the practice. I don't directly work with them, but in my practice, there are PAs and NPs, yes. And did I consider anything except medical school? I didn't. I would be lying to you if I said I did, but I was pretty much 4 years old when I said I wanted to be a doctor. So that was it. People will ask me, "Oh, are your parents doctors? Is that why you chose medicine?" They're not. No, my dad's an engineer. My mom works in administration. It was just something that spoke to me from a very young age. So there's nothing else that I had ever wanted to do. Do you have advice for letters of recommendation and gaining a research opportunity? I know right now it's hard because of COVID. I don't know what your schools have available to you. I hope that all of your undergrad schools have a pre-med advisor. If you haven't spoken to them, please reach out to your advisor and ask them what opportunities are available to you. Are there any medical schools or hospitals nearby that are offering research opportunities? Every school is different, so I'm not sure what opportunities are in your area, but I would say speak to your pre-med advisor. And in terms of letters of recommendation, that's going to come from your involvement in your school. So if you're doing research, you can always get a letter of recommendation from your mentor that you are working with. If you're part of any type of extracurricular organization, whoever the head of that organization is, you can ask them for a letter of recommendation. If you do any type of volunteer work outside, if you are, working in a hospital or working in a clinic, one of the physicians there you can ask for a letter of recommendation. But in general, that involves a time commitment and dedication to pursuing an activity. And again, I have no idea how things are for you at your local institution due to COVID, but please seek advice from your pre-med advisor. Okay. If any other questions come up along the way, please send them along. I'm just going to move a little forward here. So what is a rheumatologist? Many of you might not even have heard of rheumatology before, since it is a very, I guess, relatively new field of medicine. Well, rheumatologists are physicians who have undergone further training in diagnosis and treatment of musculoskeletal disease and systemic autoimmune conditions, which are commonly referred to as rheumatic diseases. So we are internists by training or pediatricians. There are also pediatric rheumatologists who then have done a further specialty training in this field. It's usually a 2 to 3 year fellowship. Well, what are autoimmune conditions? Well, autoimmune conditions occur when essentially your immune system causes inflammation in areas of the body improperly. So in short, the immune system is targeting its own body tissues as being foreign. So in a similar way to how our body fights off bacteria and viruses, your body is now starting to see your own cells and tissues as foreign, so it tries to eradicate those as well. So autoimmune diseases naturally can affect any organ system from head to toe. This includes skin, eyes, brain, heart, lungs, kidneys, your joints. Any organ system can be involved with autoimmune disease. These are some examples of autoimmune conditions. Some of them you may have heard of, some of them you may not have. This is obviously a very, very short list of some of the more common conditions that we do see. So this includes lupus, rheumatoid arthritis, scleroderma, psoriasis, and psoriatic arthritis, Sjogren's syndrome, ankylosing spondylitis, vasculitis, dermatomyositis, and along with that is polymyositis, mixed connective tissue disease, sarcoidosis, polymyalgia rheumatica, and autoinflammatory conditions. Very abbreviated list, but these are just, again, an example of a few of the things that I treat on a daily basis as a rheumatologist. But we don't only treat autoimmune diseases, we also treat musculoskeletal conditions. So this includes osteoarthritis, which is the most common form of arthritis that we see that our grandparents have when they have pain in their hands, their knees, their back. Osteoporosis, which is a weakening of the bones, they become less dense. Gout, fibromyalgia, which is more of a chronic pain condition that rheumatologists end up diagnosing because, again, patients have musculoskeletal symptoms. Tendinitis, bursitis, and many other muscle disorders are also managed and diagnosed by rheumatologists. So why did I choose rheumatology? So I went into this a little bit, but it was basically the passion that I developed for immunology in medical school, and then the love that I developed for the field when I did a 2-week elective during my intern year of residency. So rheumatology is ultimately the doctor house specialty. We are diagnosticians. Patients are referred to us when other doctors don't know what is going on. We are the mystery solvers. Our patients have complex symptoms, complex histories. Their lab work is often, not immediately evident of some particular condition. So our job is really to put all their pieces together and try to make a diagnosis. Sometimes the diagnosis will be an autoimmune condition, and sometimes the diagnosis won't be. So if you ever grew up watching Dr. House like I did, you will see that a majority of these very rare, mysterious conditions ended up being some type of autoimmune condition. The diagnoses and the treatments are incredible. The pathophysiology is really what inspires me. It really is humbling to see how certain small molecules and chemicals and cytokines are really responsible for creating a whole systemic autoimmune process. It makes you really appreciate what medicine is and to appreciate what our bodies are really capable of. The treatments are also very interesting. Rheumatology is evolving very, very quickly. I'm sure if you watch TV, you see these ads on TV for all these new medications for rheumatic diseases, Humira, Enbrel, Xeljanz, Orencia. Every year, there are more medications that are being studied and put on trials and being FDA approved for autoimmune diseases. I mean, believe it or not, back in the day, rheumatoid arthritis was treated with injections of gold into the joint. There was no way to treat these conditions. People ended up just having debilitating, deforming complications from these diagnoses, and there was no other treatment option. But we have come such a long way in the last 50 years. We can really manage so many of these diseases and put them into complete remission. And with an ever evolving field, I think that it's beautiful that we never feel like we're stuck. There's always something new. There's always something exciting that's just around the corner. And that's one of the other reasons I love this field. I alluded to this earlier as well, but quality of life was very important to me when choosing a career. I loved so many other fields, but I also wanted to make sure that I also had a life outside of work and a good work-life balance. So I chose rheumatology because it is a very lifestyle-oriented field as well. We work long hours, yes, so you could work 40 to 60 hours a week, but there are very few instances where you'll have to be called in the middle of the night. Very few instances where you'll have to be rushed into the hospital on the weekend. It's rare. It could happen, but it's rare. Because you can maintain a quality of life, that's also another reason I chose this field. Another great thing is the long-term relationships we can maintain with our patients. It's not a one-time evaluation and out the door. Patients with these autoimmune conditions, I see them every 3 to 4 months at least. In the beginning stages, I'm seeing patients every 2 to 4 weeks to see if they're improving, are the medications working for them, are they having any side effects? You get to know your patients well, they get to know you. I end up knowing my patients' kids, their parents. I know about, what's going on in their lives. They share a lot of intimate details with me, and I love that. At this point, I've been working for about 1.5 years, and I have had patients that I have seen several times that have told me that they feel like I'm a part of their family, and that is so gratifying, and that's so special to me to be able to share a relationship like that with my patients. And one of the other reasons I chose this field is because of the focus on women's health. Autoimmune conditions impact women more so than men, on average, at least a 3-to-1 or 4-to-1 ratio. Lupus, rheumatoid arthritis, these are conditions that impact primarily women. And as a women's health advocate, I felt that I wanted to be a part of a field that focuses on women's health, that can focus on educating women and empowering women, and discussing various different treatment options with women that are not just focused on pain medications or just standard of care therapy. There are lots of other complementary options as well that we use in treatment of autoimmune conditions that is outside of just also our standard immunosuppressant therapy, biologic therapy. Autoimmune conditions can impact fertility. It can impact a lot of other aspects of women's health as well. And I wanted to be a part of that journey for women that are going through these medical conditions. A question that just popped up is, what demographic of patients do you usually see the most? So I see adults from the age of 18 upward. So I see, in terms of age, a wide variety. Autoimmune conditions tend to impact younger people. So I have a lot of patients that are in their 20s and 30s. On the other hand, osteoarthritis, gout, osteoporosis, these are conditions that tend to impact older people. So I also have many patients that are 60 plus. So in terms of age, I see everything. In terms of women or men, I tend to see slightly more women in my practice, just again, because autoimmune conditions impact women more. I would say the percentage is about 60% women, 40% men. And in terms of ethnicity, I also see everything. I work in a part of New York that is relatively still diverse. So I see patients from all sorts of different backgrounds. And that is, again, why this field is exciting. It's not just narrowed in on a certain demographic. You see a wide variety of patients. Another great question. Did you ever find it hard to grapple with the fact that you're not curing your patients? Yes, of course. So autoimmune diseases, unfortunately, they're not curable, right? They're manageable. If you stop treatment for many of these conditions, there's a very high chance that the symptoms will come back. I do find it difficult to tell patients that their symptoms may never really go away and they'll need treatment for life. But what's also beautiful is that we can have them maintain a very healthy quality of life, and we can enable them to pursue a completely normal lifestyle and not let their disease really define them, because we are able to treat and manage their condition by calming and maintaining their immunity. So yes, they're not curable, but they are manageable. And if I see a patient that tells me, Dr. Shah, my pain is gone, my inflammation is gone, I can walk, I have no more breathing difficulty, my, debilitating rashes are all gone, that to me is a win. Even though they'll be on medication, to me, it's still a win that they are able to now feel, quote, normal, or reach a sense of normalcy for them. All right, moving forward. So in rheumatology, people will say, oh, do you just treat arthritis? No, we don't. We treat over 120 different unique diseases that are very complex in nature. No two patients ever have the same symptom and presentation. Never. There will never be two patients that have identical blood work, identical physical exam, identical chronology. Every patient is unique. Every patient is different. And that's something else I love about this field, along with the fact that, you're always a student in medicine. It's not that you're just done with boards and you're done. You are always learning because, like I said, the field is ever evolving. And I love that. I love being a student. I know most people laugh when I say that, but I love being a student. To this day, I love being a student. I'm always reading. I'm always, finding other avenues to expand my knowledge. But lifelong learning is an important part of medicine. So it's another reason I love rheumatology. And it's also a very respected field. Like I said, we are a very small branch of medicine where we see patients that have very complex, mysterious symptoms that other doctors aren't able to figure out. So when you are able to evaluate them and find a diagnosis, you are automatically not only just given a sense of, differentiation, but you're given a lot of respect by your colleagues, your other doctors, your patients. It is every field of medicine is respected, but because rheumatology is such a small field, there are not millions of rheumatologists, across the country. It's a very small field of medicine. It is something else that I find special about it. The community, you will learn over time, the longer you stay in the field, how you will quickly get to know a lot of your colleagues across the country. And in terms of rheumatic diseases, these aren't very rare. 50 million Americans, that's about a quarter of the population, they have an underlying rheumatic disease. And chances are you know someone that at least has one diagnosed rheumatic condition. And right now in the US, there are only about 5,000 rheumatologists, but it's expected that within the next decade, there will be a shortage because the rheumatologists that have been practicing for a while are retiring. And as our population is aging, and as we are able to have better resources to diagnose autoimmune conditions, there will be a need for rheumatologists. A question that just came up, do I perform any procedures? I do. So I myself do several joint injections, and these are primarily injections that you will do in joints that are bothersome to patients. So you will treat osteoarthritis, gout, trigger finger, bursitis, tendinitis. So I do steroid injections in knees, shoulders, small joints of the hand, trigger finger injections. Besides usually, these types of procedures, we don't do any type of surgery, but these procedures are in-office procedures. We will inject, gel injections for our patients with osteoarthritis. We will do, in terms of other procedures, we also do medication injections in our office. And some of these are subcutaneous injections, some of these are intravenous injections. So procedures are limited. They are primarily joint-related procedures. We don't do surgeries, but still every day, maybe there'll be some variety. Sometimes I'm doing 2 to 3 procedures a day. Sometimes it's 4 to 5 a day. Depends on the day. So we covered a little bit about what rheumatology is. I just want to review a few patient cases just to give a couple examples of what autoimmune diseases and rheumatic diseases are. Please feel free to keep asking questions. I'll try to get to them along the way. So our first case, we have a 32-year-old woman who presents to her doctor reporting bilateral hand pain and swelling for the last 8 weeks. She has associated morning stiffness for about an hour. She's had mild relief from over-the-counter Motrin. She has difficulty opening jars and has noticed decreased strength in her hand. So what other questions do you want to ask her at this point? Well, when you're trying to determine what type of inflammatory joint condition a patient has, you have to really get a full history, a full review of systems. You will get comfortable talking to your patients. If you're in medical school or if you're even in undergrad, I'm sure that you may have had some lectures already on how to obtain a history. That is going to stick with you throughout when you are in rheumatology. So the questions that I would ask: which joints are bothering you? And the patient will typically point them out. Have you had any other symptoms? Fevers or rashes, shortness of breath, any trauma or falls? Could that, if the person is complaining of, hand pain and they fell on their hand, should we be considering a fracture? Have you had any major recent lifestyle changes or stressors? Any new medications? There are lots of things, medications, vitamins, supplements that can also cause joint-related pain. So you want to go through all of this with your patient. And you need to get a basic medical history. Again, to all my med students, you have, of course, probably gone through this already. I ask all of my new patients these questions every single time. These are not skills that you will lose. These are questions that are critical, especially in rheumatology, to figuring out what the patient's diagnosis is. Past medical history. Do you have any other known medical problems? And if a patient says no, then my next question is, do you have any conditions that you take medications for? You will be surprised the number of times a patient will say they don't have any medical issues. Then you ask them about medications and they will know about 2 or 3 different medications they take for diabetes, a medication they take for asthma, a medication that they take for cholesterol. So asking a question a couple different ways is going to be a necessary skill that you will develop along the way. Any major surgeries is also important to understand to gain an idea as to what the patient's other medical comorbidities are. Patients will say, I have no medical issues. And then when you ask about surgeries, they'll say, oh, yes, I had a quadruple bypass 2 years ago. And that will, again, alert you to what other comorbidities the patient may also be dealing with. Family history. Do you have any family members with autoimmune diseases? It's a question that I ask. Why is that? Is every autoimmune disease necessarily genetically inherited? No. I mean, even studies that have been done on identical twins show that even if one twin has rheumatoid arthritis, the chance of another twin developing it, identical twin, is 12%. So it's even, of course, less so in siblings and even less so in a parent-child relationship. But we know that autoimmune conditions can really cluster in families. So if a patient says that they have multiple family members with diagnosed autoimmune diseases, it will also alert you into thinking what the patient's risk may be. And social history. Do you smoke? Do you drink alcohol? Any illicit drug use? And what is your occupation? Why do we need to ask this? Smoking is actually a big risk factor in the development of rheumatoid arthritis. It is a big factor in the development of psoriasis, along with exacerbation of underlying autoimmune diseases. Alcohol can be a contributor to development of a couple different autoimmune diseases, particularly gout. Any illicit drug use. So, IV drug use, including, heroin or anything along those lines, can also lead to inflammatory arthritis in terms of a reactive process. Important to ask. And why do we care about what their occupation is? Because that will also tell us what are their environmental exposures. Do they have any types of chemicals that they're exposed to on a daily basis? Could they be dealing with any type of overuse injury from repetitive, movement of their hands or any extra prolonged walking? These are all things that matter. So critical to get a full medical history on every single patient you see. Physical exam. I cannot emphasize enough how important examining your patient is in any field, but especially in rheumatology. We focus on autoimmune and inflammatory diseases, which I said earlier can impact any organ system. So a head to toe exam is needed. It is critical. Anywhere from looking for a rash on their scalp to looking for ulcerations on their toes. You must do a full physical exam, especially on every single new patient. So if you're in med school, guys, and if you're interested in rheumatology, use this time to really perfect your physical exam skills because it will be needed in your daily practice. So for our patient, we should be examining all of her joints since that is one of her major symptoms. So we also should be listening to her heart and lungs, feeling her lymph nodes, looking at her skin and evaluating her eyes and looking at her muscle strength to see if there's any abnormal findings. This is what the hands of our patient look like. So what do you appreciate on initial glance? It looks like her fingers are swollen, right? It looks like she has some enlargement of her middle finger. It looks like her whole front part of her hand is very swollen. several of her knuckles here, which we call MCPs, metacarpal phalangeal joints, look swollen. Several of her PIPs, which is proximal interphalangeal joints, appear swollen. When I press on these joints, she flinches a little bit. She says it's very painful to touch. These joints are warm. I can feel that there's fluid in them, and they're obviously very swollen. So now in terms of next steps, what diagnosis are we considering? Well, in the setting of her symmetric joint inflammation, young age, the duration of symptoms, we have a high suspicion for rheumatoid arthritis. So what I would do at this point is I would obtain blood work to look to see, are there any antibodies that are suggestive of rheumatoid arthritis? I would look to see what her levels of inflammation are in her blood. We would then probably start a treatment at that visit. I would probably put her on a course of anti-inflammatories or even prednisone to help reduce that inflammation. And I would have her come back within about 1 or 2 weeks. And at that time, we would talk about her blood work. We would see how she's feeling. And then we would move on in terms of our treatment plan, again, depending on her lab results and her outcome to the treatment that I started. Any questions about that first case? In the meantime, I'm going to answer just one more question that came through. When you are making a decision for a patient, how important is their input in the diagnosis and treatment? How do you make sure the patient's concerns are met? I do not practice a paternalistic model of medicine. Every decision I make is always after discussing everything with the patient. So I don't decide for the patient. We decide together. Every single time, I will be sure to tell a patient, these are our treatment options. We have option A, option B, option C. I will list out the medication. I will list out all of the side effects, duration of treatment, frequency of medication administration, all the potential side effects, the need for blood work. I will do that for all of the options. I will then ask the patient, what are you comfortable with? What are your thoughts? I then have a full conversation with the patient's concerns are. I will listen to them first. Listen to what their questions are. What are their long-term concerns about treatment? What are they most worried about? Then if they ask me, well, Dr. Shah, what do you think? I will tell them what the evidence in the medical literature shows. I will tell them, well, medication A has this percentage of improvement seen in patients. Medication B is this percentage. In my practice, I have seen the best results with this treatment or that treatment. Then we decide together. I never decide for a patient. I will always decide with them. And that is just the way I practice. I know different doctors have a different model that they go through, but to me, it is most important that a patient's concerns are met. So something else that I have learned in my last year is when I am done discussing a treatment with a patient, I don't ask them, do you have any questions? Because sometimes patients will just say, no, I don't. I ask them, what are your questions? Tell me what your questions are, because it is inherent that there will be questions or concerns. If you ask someone, do you have any questions? They might be a little bit turned off, but instead saying, what are your questions? You will be sure to address anything that the patient is thinking that they haven't already expressed. This is something, again, I learned over time. These are not things that you pick up on your first day, but to me, patient comfort is most important because that will improve patient compliance, it will improve patient outcomes, and it will improve a doctor-patient relationship. How often are you consulted by physicians of other specialties? Very often, very often. So in rheumatology, very rarely will a patient come to you directly. Well, not very rarely. I should say about a quarter of the new patients that I have are patients that decided on their own that they wanted to see a rheumatologist. A majority are patients that are sent to me by other doctors. Primarily, it will be their primary care doctor, but I will get referrals from dermatologists, ophthalmologists, pulmonologists, cardiologists, nephrologists. I mean, any specialty that you can think of, at some point will send a patient to me if they have a further question or they're concerned or they're saying there's something doesn't seem right. So, I mean, you will see patients coming in from all variety of specialties. And again, a good percentage might even come in on their own. But in my practice, according to my experience, a lot of the patients are due to referrals from other doctors. If you have a family history, mom and grandmother, for example, of rheumatoid arthritis, is there anything you can do to preemptively prevent or curb the disease process? Well, particularly with rheumatoid arthritis, we know that smoking is a big risk factor. So if you have a family history, be sure to not smoke, A, for just maintaining good health, and B, for prevention of RA. And the second thing is, from autoimmune conditions, we believe there is a genetic predisposition along with environmental factors that come into play. So in general, whatever you can do to maintain good health, eating a healthy diet, exercising regularly, getting enough sleep, a diet that's rich in fruits and vegetables and antioxidants. There's no one particular advice. I don't have a supplement to tell you to take, but just maintaining good health, reducing the amount of stress on your body, not smoking. This is the best way that you can go about it. The next thing is, if you already know you have a strong family history, and if you start to notice any symptoms that are similar to what your family members have, seeing a rheumatologist sooner rather than later may help to get a diagnosis quicker and to be initiated on treatment sooner rather than later. All right, guys, moving forward to case 2. So we have a 61-year-old male presenting with left big toe pain and swelling for 2 days. The joint is red and warm, and patient cannot bear any weight on that foot. The pain started suddenly a day after the patient celebrated his birthday, indulged in some red meat, some seafood, plenty of alcohol. He's had a similar episode in the past, no recent trauma or injuries. What questions would you ask him? So, similar to what we asked the first one, you always want to be able to understand, are there any other joints that are bothering you? Do you have any fevers? Why do we ask about fevers? Because an infection of any type can also lead to joint pain and swelling. Many of you, if you've ever had the cold or the flu, one of the symptoms that you will feel is joint pain. So you want to know, have you had any fevers? And did you try any over-the-counter medications to help? Did you try taking a Motrin or Tylenol or an Advil? Did you have any relief? Why is that important? Because if there's any type of joint inflammation, you would hope that an anti-inflammatory can also help reduce some of those symptoms. So this is what our gentleman's toe looks like. So you see the large area of redness and swelling. When I press on the toe, he screams in pain. It is incredibly painful. He can't put on a shoe. That joint that's involved is what we call the first MTP, metatarsophalangeal joint. The rest of the exam was really fine. He had no other joint pain, no other joint swelling. It was this isolated joint that was enlarged. This is a very classic case of gout, you guys. This is sudden onset joint pain and swelling in a single joint. This is the most common presentation. You could have multiple joints that get swollen and painful as well. But what is gout? Gout is an accumulation of uric acid crystals that accumulate in the joint and cause inflammation and pain. So we all have uric acid crystals floating around in our blood, but if it gets oversaturated, these crystals deposit themselves into joints, and joints are sterile environments. There's not supposed to be any type of crystal or bacteria or anything there. So if the body recognizes that there is something there that shouldn't be, it mounts this major inflammatory response that causes a great amount of pain and inflammation. It is triggered by red meat, seafoods, and alcohol, because when your liver metabolizes these products, the breakdown is a purine, and purines lead to the production of uric acid. And gout is actually one of these rheumatic conditions that we see more commonly in men, less commonly in women, but I have plenty of female patients that have gout also. So before I move on, gout is not an autoimmune disease. It's considered a rheumatic disease because it involves the joints, but it's not your immune system, quote, attacking itself. This is just an inflammatory response to a trigger of something that was there. All right, before we move on to our third case, I just want to answer a few more questions here. How do you help patients if they do not have access to obtaining a healthy lifestyle or receiving medical care due to their socioeconomic status? So I will counsel as much as I can. In medicine, it is hard to, of course, spend an hour with each patient every day, but I will try to take the opportunity to really just sit and talk to my patients about the importance of it. Attaining a healthy lifestyle is not something that is out of reach for everyone. No matter what your socioeconomic status is, I believe there is a way to attain a healthy lifestyle. There's always a way to have a healthy diet and to find an ability to exercise. You don't have to have a fancy gym membership to exercise. You can literally do workouts. You can exercise in your home. And in terms of, healthy eating habits, I know it's hard. Listen, getting a fast food burger is going to be much cheaper than getting a healthy salad, but there are ways that we can make small changes at home. For my patients that are overweight, I will spend the time to counsel them that weight loss is about 70% diet, 30% exercise. So just try to really think about what you are eating and try to modify your daily intake of calories. Try to cut down on the sugary foods, the fatty foods, and try to replace that maybe with some healthier options. I will literally review with them what they are eating on a daily basis, and I will try to give them a more tailored approach to how they can modify their eating habits. It all depends on what the patient's receptivity is as well. If they're willing to see a nutritionist, I will always send them to a nutritionist to help guide them on weight loss and healthy eating habits. If they smoke, I will talk to them about the importance of smoking cessation, the risks of cardiovascular disease and lung cancer. I will do my best to take the time to do these things because I strongly believe that attaining a healthy lifestyle is not impossible, no matter what your socioeconomic status is. And some patients just seem to be on this, they have a notion that because of their social status, they just cannot be healthy, and that's not true. Anybody can be healthy as long as they have the willpower to be able to get there. So I will do my best to talk to my patients to see what their roadblocks are. Is it the fact that they work too much? Is it the fact that they don't have help at home? I will try to help them find an option, but I will encourage them to be able to look within and to examine their own lifestyle and see what changes they can make on their own. Another question, can gout be surgically removed, or is the cure a medication to reduce the size over time? So gout can be treated. If a patient, like the patient that I just showed, going back to this slide, if a patient has a toe that looks like this, we can treat this level of inflammation. We can treat them with an anti-inflammatory. We can treat them with a steroid at times. That's the controlled acute inflammatory process. If I do their blood work and I see their uric acid is sky high, they have multiple other risk factors, we'll have a discussion on putting them on a medication that can over time reduce their uric acid levels. If they reduce their uric acid levels and make lifestyle changes to reduce the intake of, like I said, red meats, alcohol, seafood, they exercise more, they are able to, manage to get the uric acid to be sustained at a lower rate, then it reduces their risk of gout flares. If patients have accumulation of these uric acid crystals within a joint for a long period of time and they go without care, they can develop what's called a tophus, or multiple of these is called tophi. You can develop them in your fingers, in your wrists, in your toes. You can develop them even in your ears. If these tophi become very painful and debilitating, they can be surgically removed. But for cases like this, in this patient case that I just discussed, the treatment is not surgery. It's to treat the inflammation and to prevent it from happening again. This is another great question. Does one ethnicity predispose people to rheumatological disorders than the others? So this depends on the rheumatic condition we are talking about. For example, lupus is seen more commonly in the Hispanic and African American population. Rheumatoid arthritis, we see more commonly in the Caucasian population. Other the other rheumatic diseases, where we talk about Sjogren's and vasculitis and misconnective tissue disease, they vary across the spectrum. But there are some conditions that, yes, are seen more commonly in certain ethnic groups than others. But overall, there's not just one ethnicity that suffers from rheumatic disease more than others. All right, everyone. Keep your questions coming as well. I will try to get to as many of them at the end as I can. This is the last patient case that I wanted to talk about. We have an 18-year-old female who is presenting with fevers, joint pains, rash on her face, and chest pain for the last several days. She's also having difficulty breathing and new swelling in her legs. has never had symptoms like this before. She hasn't traveled and is not on any new medication. So for her, just listening to what she described as her symptoms, there's clearly multiple organ systems that seem to be involved. So getting a full review of systems is going to be critical. For my med students, you may have already gone through courses where you are taught on how to obtain a review of systems. When I was in medical school, I had one of those sheets that I used when I was doing my patient practice interviews, started from the top down, constitutional, eyes, ears, nose, throat, full way down. I have this in my head now after all these years, and I will go through that with my patient. So with the symptoms that she said, what I would start off with is, how long have you been having the fevers for? Do you have any type of inflammation of the eyes, any headaches, any blurry vision, any difficulty with your balance? I would ask her if she's had any ulcerations in her mouth or nose. I would then go through and say, do you have any swelling in your neck, which is suggestive of swollen lymph nodes? Moving further down, any difficulty swallowing or chewing? Have you had a cough? You have had chest pain, but any pain when you're taking a deep breath? Do you have any productive cough at all? Moving further down, any nausea, vomiting, any diarrhea, any constipation? Have you noticed any blood in your stool, any blood in your urine? Have you noticed any bubbles in the urine? Have you had any pain when you are going to the bathroom in any way? Moving further down, we want to now start talking about her extremities. Have you had any type of difficulty moving certain parts of your body? Do you feel weakness in any of your muscle groups? Do you have any numbness or tingling in your arms or legs? Any rashes that you have seen anywhere else on your face? Any rashes on your arms? Any ulcers on your fingers or toes? This is an example of a full review of systems that I go through with all of my new patients, and especially for some ones that are young with multiple symptoms such as her. Full review of systems is very necessary. We want to figure out also how long have these symptoms been going on for. We want to get a timeline. When did they start? What started first? What came afterwards? What is her family history? What is her social history? Similar to what we had reviewed earlier. Now on her exam, this is what she looks like. She has this rash on her face. This is what we call a butterfly rash, a malar rash across her face. It is a little bit tender to touch. Her legs are swollen all the way from her mid shins down to her feet. There is notable swelling. She has tenderness on touch of many of her joints. Her heart rate is very fast. She's visibly uncomfortable. What is likely her diagnosis? Likely her diagnosis is systemic lupus erythematosus. This is a complex autoimmune condition that can cause multi-organ involvement. And it is really characterized by the presence of certain autoantibodies in the blood that cause systemic inflammation. But the physical exam is what we are seeing first. We are seeing her before we see her blood work. So in our patient, she has this malar rash. She has inflammatory arthritis. She likely has what's called nephritis. And a question just came up, is that what would the bubbles in the urine indicate? Bubbles in the urine would indicate that there is protein leaking out from her kidneys. Her kidneys are inflamed, and the small units of the kidneys called the glomeruli are not able to filter the proteins back in. So she is excreting these proteins, which is what's causing bubbles in these bubbles in her urine. She's also dealing with fevers. This is all consistent with systemic lupus. Now, again, you are making this diagnosis before you are even getting any type of blood work, which is why physical exam and review of systems is so important. You need to diagnose these patients quickly and be able to start them on treatment to prevent further organ damage. You can, if you're in primary care or if you're an ER doctor, recognizing the symptoms and getting the patient referred to a rheumatologist or even a nephrologist can really help to reach the diagnosis. For her, what we would do is we would probably start her very quickly on a high dose of steroids to try to bring down this inflammatory process, and at the same time, get a full panel of blood tests done. Figure out is there any evidence of kidney dysfunction, looking at her creatinine, looking to see her basic blood counts. Has she developed anemia? Is her hemoglobin stable? Are her platelets stable? What is the element of lupus activity that's going on? And this would include a pretty thorough lab workup, but that lab workup does not delay the diagnosis and treatment. You have to have a sharp clinical judgment and be able to treat these patients sooner rather than later. Lupus is one of these conditions that is very wide on a spectrum. Some patients literally only suffer from a little bit of a skin rash when they're out in the sun. Others can have life-threatening multi-organ damage. So like I said, no two patients are the same. It's what makes the field beautiful. But lupus is one of the more challenging conditions to treat in rheumatology. We can definitely get patients into remission, but this, along with many other conditions, there's not a cure for it yet. And that leads me into how do we treat autoimmune diseases? So there is not one single treatment plan. I touched on this earlier, but my treatments are really based on my conversation with a patient. It's dependent on what their exact diagnosis is and how severe is their disease. What other medical conditions do they have and what other medications are they on? We are not going to put patients on immunosuppressants that are currently also dealing with a major infection, for example. What are their lab results showing? If patients have already life-threatening anemia, we're not going to put them on further medications that can possibly exacerbate that. And again, we have a thorough discussion of risks and benefits with our patients. You know, I have yet to this day start a patient on a medication that they're not comfortable with. We have to review what our options are in detail. And these conditions, a lot of the ones that we mentioned, there are multiple treatment options here. We can treat autoimmune and inflammatory diseases with multiple different medications. We can start with anti-inflammatories, and this can include, you know, over-the-counter medications or even prescription strength medications such as naproxen and meloxicam. Prednisone is something that we would use to acutely manage an inflammatory process. Prednisone is never a long-term treatment, for it can have many side effects. So we never use it long-term. We only use it in a short-term setting to bring down the acute inflammation while we are working on getting a workup and then figuring out what the next step is. For a question I believe just popped up regarding steroids. So what is it about steroids that decreases inflammation? So this is a very great question, and I could probably spend a whole hour talking about prednisone. But steroids work on essentially the production of inflammatory molecules. So if you want to talk about this a little further, I promise I will get to it at the end. But prednisone, what it does is that it really works on the intracellular mechanisms of how inflammatory molecules and cytokines are created. So it reduces the production of inflammatory molecules, essentially. But it is a very, very complex mechanism of action. There's involvement of NF-kappa B. We're going all the way back to our underlying pathophysiology. So if you're very interested, please actually even send me a direct message on Instagram, or we could talk about it later at the end here, but I will get to it. I know we only have a few minutes left, so I want to get through this as quickly as possible. For our patients that have gout, osteoarthritis, that have a single joint that's really bothersome, we do intra-articular injection of steroid, which is usually typically depomedrol or Kenalog, and that is also a viable treatment option. We use oral immunosuppressants to treat many of our rheumatic conditions, and these maybe some of them you've heard of. I'm just going to list them out: methotrexate, sulfasalazine, azathioprine, hydroxychloroquine. These are all examples of oral DMARD. DMARD. That is a disease-modifying anti-rheumatic drug. So we use these to treat autoimmune diseases. Sometimes we need to even use biologics, which can either be subcutaneous or intravenous. And again, these are a lot of the things you hear about on TV that have been coming out: Cosentyx, Stelara, Taltz, Humira. These are all examples of biologics. A biologic is a medication that mimics a biological part of our immune system. So there are several small cytokines. If you've been following along on my Instagram page, I will do posts talking about our adaptive immunity, innate immunity, talking about these various different parts of our immune system that these medications can treat. So, you know, we have a large variety of options right now in our armamentarium compared to what we did 50 years ago. So we have come a long way. And a lot of these medications have really only been around for about 10, 15 years. So it's wonderful that we have more treatments for our rheumatic conditions now. and there's still plenty more that are in development. And in patients that have severe disease, we use chemotherapy. So in chemotherapy or in cancer, these medicines are used to kill off cancer cells. In severe autoimmune disease, these medications are used to really try to kill off the overactive immune cells that are causing a lot of organ damage. So we end up using medications like cyclophosphamide or rituximab, which you may know are used to treat several cancers, but we use them in autoimmune conditions as well. So a few key points here. Rheumatology is a challenging yet gratifying, ever-growing field. One of the things that I love about it, one of the things that I hope that you find interesting about it, there's a large spectrum of medical conditions. It's really never a dull day. I see so much on a day-to-day basis, so many different types of patients. I get to meet so many beautiful people from all sorts of different backgrounds, which not only inspire me, but they encourage me to keep learning more. And again, the long-lasting patient relationships is something that I find so beautiful and special in this field, along with the fact that rheumatology offers a really great work-life balance. I really do hope that you found this presentation interesting and perhaps you learned a little bit more about rheumatology. One of the things that I learned in medical school that I have carried with me through and through is this beautiful quote by Sir William Osler. It's the good physician treats the disease. The great physician treats the patient with the disease. As a rheumatologist, I don't look at a patient as the patient with rheumatoid arthritis. I treat them as a person. You want to treat the patient as a whole, not identify them by their autoimmune condition, but really encourage them and empower them to live as healthy of a lifestyle as you can, not just treat one disease that they have, but just to treat them as a person. And I try to adhere to this every single day. And I hope that this is something that you're able to take along with you as well. So thank you so much for your time. I really appreciate all of your effort in being here, and I'm open to taking questions as well. All right, so a few more things that did come up for those of you that are still sticking around. How long are your patient interactions on average? So it depends. So I am seeing every day new patients, consults, and follow-up visits. So follow-up patients are patients that I already have an established relationship with. I've already started them on a treatment plan. I'm just following up with them to really see how they're doing, reviewing their lab results, make any changes to their treatment if necessary. So usually those patient interactions will, for me, be about 15 to 20 minutes. For my new patients that I'm starting from the beginning for, that are coming to me referred by another doctor, for them, I'm really getting a full history. I'm getting a full review of systems. I'm doing a complete full physical exam, spending a lot of time in reviewing all of their previous workup that they've had, their previous lab work, their previous imaging results, all of their previous notes from other doctors. So for them, I spend a longer period of time, anywhere from 30 minutes to 1 hour. I have had many complex patients that have transferred care to me from other doctors that they've seen. And when you're reviewing a lot of other information, it can take sometimes upwards of 30, 45 minutes, but each patient interaction varies. How long do you spend with patients as opposed to doing administrative work, especially compared to other specialties? That's a good question. I cannot speak for my colleagues of other specialties. I cannot even speak for colleagues in the same specialty because every doctor is very different in how they go about it. I would say that I spend a majority of my time in patient care. Now, documentation is obviously more emphasized now than it has been in the past. So yeah, you are spending some time documenting. Luckily for those of us that were born in the computer keyboard era, we have become a little bit more adept at typing. We tend to type faster than our colleagues that have been practicing for longer. So I would say that it does give me a little bit of an edge that I'm able to type a little bit more quickly, and I try to remain organized. I do my notes. I finish my notes before the end of the day. I do not bring my notes home. I want to finish all my work while I'm at the office. It's hard to really give a breakdown on how much time I spend on administrative work because yes, as a rheumatologist, we are dealing a lot with insurance companies. A lot of our medications need authorization. It requires approval. We need sometimes to go back and forth to get medications approved. So that does take a little bit of time, but luckily I have a great staff that helps with all these authorizations. So I'm not spending hours on the phone with insurance companies every day. The most administrative thing that I would say I do is really doing my notes, but that's also a part of patient care. I realized that working in a large private practice, how much other doctors rely on your notes to understand what is happening with the patient. And I do take my time in having detailed notes, very clear, concise notes as well. So I don't know. I would say maybe I spend 5 minutes per note on average. If there's a lot of information that I am gathering from other doctors, or if I have a big stack of paperwork to go through, it will obviously take me a little longer. But I would say maybe like 5 to 6 minutes per note. And then per patient interaction, of course, as we talked about, it varies. So let's see. Some other great questions that have come up. What amount of people go into remission for lupus? So I don't have an exact percentage for you because it all depends, again, per patient. It depends on the comorbidities and the severity of the lupus symptoms. It depends on what the patient's other medical problems are. It depends on what their treatment has been previously. In rheumatology, there's something that we strive for called treat to target. So treat to target being remission. So we will modify our treatments until we can get the patient to go into remission. So I can't say that I have X amount in remission because the patients that are not in remission, I'm working to actively get them there. So the goal is to get patients into remission, but in terms of percentage, I don't have one offhand for you because, like I said, the patients that are not yet there, their doctors are working to get them there eventually. With the pandemic, how do you balance the need to suppress the immune system to treat autoimmunity with the risk of more severe COVID, especially with patients who are also essential workers? That's a beautiful question. So this is something that has been looked into by the American College of Rheumatology and various immunology associations. So it's, again, a risk-benefit discussion. I have had so many phone calls regarding this with my patients, and I continue to on a daily basis. It is what the patient's priority is. I will emphasize to them that their autoimmune disease necessarily does not put them at risk for getting COVID. The fact that they are on immunosuppressants doesn't increase their risk of getting COVID, but theoretically, if they were to contract it, it might make it a little bit more difficult for them to be able to fight it off. From what we know so far, there is not an increased risk of death in patients that have autoimmune disease on immunosuppressants. So I try to use this as a point to explain to patients that, they really shouldn't stop their treatment because the risk of having complications from their autoimmune condition may outweigh the risks of contracting COVID or even severe COVID. But this has been a struggle for a lot of my patients. I had a lot of patients that just stopped their treatment and they came back a couple months later with a severe flare-up of their disease, and it was more difficult to get them to get back into back to their previous state. It is a complex topic and it is very difficult to convince somebody to do something, and I'm not here to convince my patients. I want to just educate them. So I will let them know that, they really shouldn't stop their treatment because I don't have any solid data to say that there's increased risk of death from COVID. But yes, I will tell them it may take you a little longer to fight COVID off compared to your counterpart who doesn't have a rheumatic disease and is not on immunosuppressants. But in general, if you're just practicing, good hygiene, you're wearing a mask, you're washing your hands, you're avoiding the large crowds, there is not going to be an increased risk of you getting sick if you are just adhering to the guidelines and recommendations that are being advised by the CDC. Question, how would you handle not being able to diagnose a patient if this ever happens? How would you be able to handle not being able to diagnose a patient? I don't know exactly what I was referring to, but I think that what this person is asking is there ever a time that I can't make a diagnosis? Yeah, I mean, like I said before, rheumatology and the immune system is very complex. So there may be a time that, a patient has these abnormal symptoms, but their blood work is all completely normal. Their physical exam is also completely normal, but they have symptoms that I'm unable to explain. I will do my best, but there are times that I can't come up with a diagnosis. And this is something that we learn in medicine as doctors. You know, we always want to be able to give a patient an answer. They come to us looking for an answer, and it's really disheartening when we cannot give one. But it is also one of the truths of medicine is that we will not always know. We will not always be able to fix, and we might not always be able to offer a solution. And at some point, we do need to come to terms with that as well. It doesn't happen often, and trust me, it's a little unsettling when it does, but it is one of the, you know, the truth of the field. You might not always be able to give an answer, and that is okay. You just have to be comfortable with saying, I don't know. You have to be able to be comfortable saying that. You can always send the patient to somebody else, another specialist. You can send them to a tertiary care center where there is a big academic institution. You can send them somewhere if you don't know, but you have to get comfortable saying it. I don't know. What's the difference between rheumatology and immunology? So they are very closely intertwined. Rheumatology and autoimmune diseases are based on immunological changes that happen. Immunology is the foundation of understanding what rheumatology is. However, there are doctors that are especially immunologists who are also allergists. So immunologists do not treat autoimmune diseases like rheumatoid arthritis and lupus and such, whereas rheumatologists do. Immunologists can help to treat, inherent antibody deficiencies that a patient might have. So for example, if you have what's called, hypogammaglobulinemia, your body just doesn't make enough IgA, immunoglobulin A, or IgG, immunoglobulin G, you're more prone to infections because of this. An immunologist would be able to help treat that. Immunologists can help to diagnose various immunodeficiencies. Rheumatologists don't usually diagnose immunodeficiencies. We usually diagnose conditions of overactive immunity. So while the fields overlap very much so, we treat very, very different conditions. Hopefully that kind of helps. Immunologists are usually also allergists by training. Their fellowship is usually allergy immunology, so they will treat various different allergies as well. What's your take on sugar and its effect on the body? I've heard that sugar is to blame for a lot of the inflammation physicians see in patients. And then the second question is, are you ever asked to diagnose something other than autoimmune disease? Okay, so what's my personal take on sugar and its effects on the body? Well, anything in excess has undesirable outcomes. Sugar is considered inflammatory to some people. Again, what we are now learning in the field of rheumatology is the close mind-gut connection and the gut immunology connection. So the things that we eat and digest play a role in our immunity. Our gut is made up of the largest immune aspect of our body, actually. And the bacteria that reside in our gut are responsible for a lot of our immune-mediated functions. We are learning every day more about this. We know that what we eat can definitely make us feel a certain way. To some people, certain foods are, quote, inflammatory. Some people will have tomatoes and they will feel like their joints get swollen. Some people will have dairy and feel like their joints get swollen. That is because their body is just not tolerant to it. Some people will have sugars and they will feel unwell, fatigued, lethargic. I think in general, we see that sugar causes this high and then a crash. I don't believe in extremism in any way. I'm not 100% anti-sugars. I'm not 100% for it. I think that in general, any type of intake in moderation is okay for you. Everyone's body is very different. I don't think that sugar is 100% to blame for inflammation, but it may be a contributing factor to some people. And can I be asked to diagnose anything other than autoimmune diseases? Absolutely. I mean, so as a rheumatologist, we're not only treating autoimmune conditions. Again, like I said, we also treat other musculoskeletal conditions like osteoporosis, advanced osteoarthritis. We will treat gout. We will treat tendonitis, bursitis. But also we will end up trying to help other doctors in diagnosing conditions that are a little bit unclear to them. So patients are sent to us to help diagnose an autoimmune disease, but in terms of their workup, we may end up uncovering something else. For example, a patient was sent to me a couple weeks ago for really sharp stabbing chest pain. Sharp stabbing chest pain. Blood work was all normal, seen by cardiology, echocardiogram normal, EKG normal. It was unclear what was going on. I saw the patient. I got a full history. I spent a good amount of time doing a physical exam. I ended up diagnosing the patient with pericarditis. Started him on a treatment, followed up with him in 2 or 3 days. He was significantly better, spoke to the cardiologist, who was, of course, very thankful for the diagnosis, but that wasn't an autoimmune disease. The cardiologist was concerned that the patient had some type of rheumatic disease going on, but it ended up being an inflammatory process of the pericardium. In the same way, I have aided in the diagnosis of multiple GI issues, even inflammatory bowel disease. It is not always that we're going to end up diagnosing an autoimmune condition. We are usually referred, patients are usually referred to us to help to evaluate to see if there's autoimmunity there. But if there's not, we may end up even uncovering something else. I have diagnosed MS several times in my practice, but that patient wasn't sent to me to diagnose MS. They were sent to me to diagnose something else. But in the workup and again, through proper treatment, you will end up making other diagnoses. Let's see. How do you deal with patients not wanting treatment when you know it is best for them? Do you try to convince them or do you trust their judgment? This happens. I do not force anything on my patients. I am there to educate them. If patients do not want to be on treatment, what I do is I review with them the risks of not being on treatment. I will review with them all the possible outcomes that can happen, the debilitation and the injury that they can end up dealing with. And if they are able to express understanding of this and still not want to be on treatment, I am not there to force anything on them. I will let them be they're in charge of their own health. I will let them make that decision. Our job as doctors is not to force, it is to educate and empower our patients to be able to decide what they want to do for their health. We are not controlling anybody here. We want to help those that are suffering, but for people that want to choose to not be on therapy, it is also our job to respect that. Even if it hurts, even if we know what could happen and will happen, we can't force anything, because at the end of the day, if you're forcing someone to do something that they don't want to do, they'll probably end up being non-compliant, and you're going to leave a sour taste in their mouth as well. So I will educate. I will give them literature showing what could happen if they are off treatment. I will tell them what I have seen in patients that are off treatment. And if after everything they still say, I don't want to be on anything, okay, you are in charge of your health. It is your choice. I tell them I am available to you. If in the future you change your mind, I tell them do not hesitate to come back to me if you change your mind. And if your symptoms progress, please know that I am here for you. I end with that. Know that I am here for you. Call me anytime that you need. And that's it. I try to empower my patients. This is not, medicine is not about forcing anything on anyone. We are fortunate as doctors that we have the ability and the knowledge to be able to educate. And I try my best to spend my time doing that. With every patient visit, I will try to teach them one thing at least so that they can take that home with them, and maybe it'll make an impact on them and their families in the future. I've heard that methotrexate can have negative effects on pregnancy. How do you alter the treatment plan for patients with rheumatic disease when they are pregnant? So yes, methotrexate is teratogenic. So that means that it can cause fetal abnormalities. So first, my patients that are young, fertile patients that are on methotrexate, first I will tell them to tell me before they want to start trying to conceive, because you can stop methotrexate 3 months ahead of time, and then it is safe to try to start conceiving. Methotrexate is out of your system by then. There are other options that are safe to use in pregnancy for patients that have rheumatic diseases. So the most important thing first is to have an open communication with your patients, to let them know, to inform you when they are trying. If they happen to become pregnant while they're on methotrexate unknowingly, you have to stop the medication and make sure that they're following up closely with high-risk OB to make sure their fetus is, their pregnancy is growing normally. And like I said, there are other options. So you can use medications like hydroxychloroquine. There are certain biologics that are considered to be safe in pregnancy. I tend to refer to UpToDate a lot when I'm talking to patients about this. I will give them the exact percentages of risk. So we can, and same thing with my breastfeeding patients. A lot of these medicines, they're transmitted in breast milk. So I will review with them what percentage of the medication is transmitted, and we will make a joint decision depending on the mother or expectant mother's comfort. Is lifestyle medicine a significant part of rheumatology? For me personally, so we have to talk about what lifestyle medicine is. I don't rely on lifestyle medicine at all to solely be the treatment plan for a patient. I, as an MD, as a Western medicine trained physician, I don't practice complementary medicine or naturopathic medicine. I treat patients based on evidence-based medicine. So I will treat them based on what medications are proven to be effective, that are FDA approved to be effective. I will use science to back up any judgment. But in terms of lifestyle medicine, so what I would say is I talk to all my patients about the importance of smoking cessation, maintaining a healthy weight, eating healthy, and exercising regularly. Now, that is a crucial part for general health and well-being, but I will talk to my patients at some point during the treatment plan about the importance of this. You can say this is a form of lifestyle medicine, but I really focus on that because of the impact it has on general health. If your general health is maintained, you are more likely to have remission of your rheumatic diseases and better control of them. So I talk to all my patients about that, but I don't practice solely lifestyle medicine. I just feel that, we have to be using evidence-based treatments for our patients. I wouldn't want my patients not being on treatment and using some various herbs and supplements when we have no data to suggest their safety or efficacy. So patients will say, oh, should I use turmeric, and should I use this, and should I use that? I will tell them I don't endorse any supplements. You can do as you wish, but these are not FDA approved. So I don't personally recommend them, but I do recommend medicines that we know work. Any other questions from you guys? These are all wonderful questions that have come up so far. And if anything comes up afterwards, please do not hesitate just to reach out to me. You can direct message me on Instagram. I'll try to get back to any of you as possible, as many of you as possible. On the Web Shadowers page on the slide, my Instagram handle is there. So please do add me. You can follow me for any information about autoimmune conditions. I'm always talking about new things. Recently, I had a few posts on fevers and autoimmunity, fevers and immunity in general. Why are fevers a crucial part of the immune system? So there's some education, some things about rheumatology in general. Follow along if you continue to remain interested, and I will, again, answer as many questions as I possibly can. And if there are no other questions now, I'll just turn it back over to Sophia.
Thank you so much, Dr. Shah, for this wonderful presentation.
Thank you for having me.
Yeah, thank you so much for joining. We all learned so much from you, and thank you so much for taking the time to answer so many of our questions. We really appreciate it. Everyone, make sure to go check her out on her socials. Like Dr. Shah said, you can go to our Instagram to learn more about her. And just a quick announcement, this Friday will be the start of our January monthly roundup. So for those of you who aren't familiar with our roundups, we hold these so that you can go back and watch previous live streams that you did not attend, so you can earn credit for these past sessions. Every form for the month of January will be open this Friday at 11:59 p.m. Eastern and will close Sunday at 11:59 Eastern. You will be able to access these forms through a document that will be on our website when this roundup period opens, and every link will also be in the description of each video. And we have a YouTube playlist for each month to make it easier for you. Once again, thank you all for attending, and thank you so much, Dr. Shah. We really appreciate it.